Good morning and welcome to day 4 of the African Society for Laboratory Medicine conference, and this very important session, which is centered on the role of diagnostic integration in strengthening laboratory systems. I am George Alemji. I serve as a Senior Technical Advisor for Laboratory Services at SGAG in Washington. I will be moderating this session with my colleague, Eileen Berg. So Eileen, please can you just introduce yourself?
Good morning, everyone, and welcome to this very important session. My name is Eileen Burke. I'm a laboratory specialist at the Global Fund.
Thank you so much. Again, I just want to remind ourselves that the topic for today is the role of diagnostic integration in strengthening laboratory systems. And it's very, very important that this topic comes in today, since throughout this meeting, we've been talking about the need to walk away from silo systems to diagnostic and multiplexing system. That is just what has to happen to address multiple diseases. This session is going to go on for a very, very busy 2 hours, and it's going to be in 2 main sessions. The very first one will be remarks from some key stakeholders, and this will be followed by overview presentations, and then of course 2 country examples. Then we shall move to the second session of the presentations, which will be a panel discussion featuring very, very key and important stakeholders from funders to diagnostic manufacturers. And this will be followed again by some question and answers. And then we will move to the closing session. I just want to remind everyone that the chat is open and busy, so get all your questions in and they will be addressed accordingly. At this point, I'll hand over to my co-moderator to move ahead with the opening remarks session.
I would like to thank you very much, George. I would like to call upon and introduce Dr. Tandy Onami from the Bill and Melinda Gates Foundation. Dr. Tandy Onami is a program officer on the HIV vaccine team at the Bill and Melinda Gates Foundation. Over to you, Tandy.
Good morning, good afternoon, good evening. Greetings from Seattle, Washington. I want to welcome all of you to this important satellite session where over the next few hours we will talk about a very critical topic that was really brought home over the last year or so with the COVID-19 pandemic, where we've been forced out of our silos, if you will, because the need to integrate diagnostic testing, and many of you have risen to the challenge admirably. And so I think, you know, we've had some major learnings, and we'll use those to those experiences over the next few hours to discuss some of those experiences and how we can design strong and integrated diagnostic systems. So with those, I just want to again reiterate that the partnership with the African Society for Laboratory Medicine has been a strong one. I'm pleased to partner with my colleagues at ASLM, including CEO Ndilovu, who will have some welcoming remarks as well. Ndilovu.
Thank you so much, Tandy. Can you hear me clearly?
Yes.
Yes.
So good afternoon, good morning, and good evening to everyone. Distinguished guests, ladies and gentlemen, welcome to our session today on the role of diagnostic integration in strengthening laboratory systems and networks. We all agree that we have made tremendous progress in the last 15 years in controlling TB and HIV, as two of these regions' major public burdens. However, we still have low coverage of testing, treatment, and prevention strategies in some parts of the continent. With the addition of other important diseases such as cervical cancer, hepatitis, and STDs, more attention, the need for effective intervention that address challenges of access at both individual and population level is critical. On Tuesday, I highlighted that the increased demand for testing has applied much pressure on an already fragile and underfunded laboratory ecosystem. However, we know that several technologies, both laboratory-based and point-of-care assays, currently exist that can test, that can monitor multiple diseases, including HIV, tuberculosis, hepatitis C, human papillomavirus, for cervical cancer screening, sexual transmitted and outbreak infections. The current diagnostic gaps in the response to several communicable diseases could be supported by the optimal use of existing technologies. In the current climate of stagnant or shrinking funding, operating laboratory systems in isolation across each disease program is inefficient and costly. Unfortunately, COVID-19 didn't give us even the opportunity to engage each other once more, as well as to act together and we began to use all the available resources that we had. We were forced to leverage on a good number of these investments by other vertical programs, and so that we are funds. So today, as we deliberate on this crucial topic on testing integration to strengthen lab networks, I hope the experiences that will be presented today will urge all of us forward in scaling up diagnostics to a state where we are prepared enough to cater for current diagnostic needs, but also well-placed to respond to the current COVID-19 and future pandemics in Africa and beyond. So with these remarks, I thank you. Over to you, George.
Thank you so much for those two very, very important opening remarks that help set the stage for our presentations this morning. So we are moving into our overview presentations. And our first presentation will be an overview of multi-disease management and diagnosis from a WHO and global perspective. And this will be by Dr. Robert Liu. Dr. Liu is a diagnostic consultant for WHO and a clinical pathologist with expertise in virology, microbiology, and global health. In his current position, he advises normative guidelines, development, and country support for HIV diagnostics, including viral load and early infant diagnosis and laboratory quality and development. Dr. Liu, over to you.
Hello. Today I'd like to speak about the role of diagnostics integration for strengthening laboratory systems. Thank you to the organizers for inviting me to speak today. My name is Robert Liu. I'm a diagnostics consultant and pathologist with WHO. So in 2019, WHO and ASLM convened a molecular diagnostics integration global meeting in July of 2019 that brought together countries, donors, partners, and key stakeholders from across a variety of different diseases, HIV, tuberculosis, hepatitis, cervical cancer, and STIs, to a meeting in Geneva to discuss diagnostics integration. Here we covered four main areas: financing and resources, site mapping and optimization, systems integration, and patient considerations, all important factors when considering how to integrate diagnostic programs. From that meeting, we received a commitment from countries, WHO, and partners to move forward with diagnostic integration. We also developed a white paper of commitments and developed a best practices document. You can see from our meeting report that we reached several conclusions regarding diagnostic integration across programs. The first is that pilot programs have demonstrated successes with HIV-TB and HIV and hepatitis C integration. Integration is operationally feasible with appropriate site selection to balance expected demand. We also saw that near point-of-care testing can enable faster and increased rates of clinical action. For example, faster clinical action was achieved for both HIV infant diagnosis and viral load testing, improving outcomes, and that integrated testing does not impact the potential impact of near point-of-care testing and is a viable option to scale up near point-of-care testing. Diagnostic integration does require a network of coordinating planning. After a test is approved, programs must look at product and site selection, integrated systems, standard operating procedures and training, supervision and monitoring, clinician training and demand generation, inventory management, quality management systems, as well as data management. In the 2021 updates to the HIV guidelines, we also indicated that task sharing of specimen collection and point-of-care testing with non-laboratory personnel should be implemented when professional staffing capacity is limited. This was a strong recommendation and can also be taken in the context of integrating diagnostic programs. Through work on diagnostic integration, we've seen many potential benefits and efficiencies. In the example of integrating TB and HIV programs, we've seen increased TB case finding through targeted testing of high-risk HIV positive individuals. We can also leverage the HIV program's point of care and laboratory knowledge and vice versa. There's been increased device base through HIV procurement, and operational costs can be shared across programs. This has led to increased access to infant diagnosis, improved outcomes for patients on antiretroviral therapy, increased demand for TB testing of persons living with HIV. And this is all in the context of leveraging the existing system to accomplish this. Programs and MOHs can strive for a more optimized integrated diagnostic network, can find efficiencies across programs and diagnostic components. It also provides increased negotiating power for programs. And we have several model examples of successful integration experiences. This slide shows that there's multi-disease technology for molecular assays across a variety of major diagnostic manufacturers. For example, Abbott, Cepheid, Hologic, and Roche all have platforms that can test for HIV, a mix of tuberculosis, hepatitis B and C, HPV, and STIs, and COVID-19 or SARS-CoV-2. Overall, what we found in experiences from integration programs are several benefits and challenges. The benefits include increased access to testing, higher utilization of existing equipment, decreased turnaround times, and increased clinical action rates. Challenges include site selection. We've seen that this is critical because not all sites may be best suited for integration. Adjustments are typically required to both clinical and laboratory workflows, and there's a need for adequate human resources with increased testing utilization. Significant support is often needed to accomplish this, as well as to ensure adequate infrastructure. Patient and site mapping can be done through diagnostic network optimization, and several tools have been in development to support network optimization and mapping to ensure optimal integration. These include USAID, CHI, Ministry of Health tools, and all of these tools consider the following: patient impact, patient volumes, geography, current devices, and utilization and capacity. Financing and cost-sharing strategies are also an important aspect of diagnostic integration. To do this, we have to look at things such as the cost of new devices, extended warranty for diagnostic platforms, the cost of service and replacement of module failures that may or may not be covered by warranties, calibration kits that may or may not be included with the device, connectivity hardware and data allowance, HR training and lab operations, and mentoring and supervision. There have been several experiences from integration programs that have been recently published. This example is a study in Zimbabwe in conjunction with MSF that looked at multi-disease testing for HIV and TB using the Gene Expert platform. What they found was that it was feasible to integrate HIV testing and TB testing at sites, and it did not lead to an overload or overutilization of instruments. In fact, instruments still had excess capacity for testing to be able to respond to surges and other testing needs. Similarly, earlier this year, the Ministry of Health in Malawi and Zimbabwe, in conjunction with CHAI, published their study looking at the feasibility and impact of near point of care integrated TB and HIV testing. Similar to the previous program, this study also found that integration was feasible across a variety of sites and demonstrated that integrating TB and HIV testing led to increased access to testing, but again, did not lead to overutilization or overwhelming of testing sites. Third example was published this year from South Africa, which looked at programs that had already integrated HIV tuberculosis services in primary healthcare clinics and did a cluster randomized controlled trial on quality improvement of these programs. I think this study is important because it shows that ongoing quality improvement is necessary for all diagnostic and treatment programs and can also help continue to integrate services as well across disease areas. So in summary, as we move forward to diagnostics integration, we not only look at how to integrate diagnostic platforms, we can look at how to integrate this into the larger laboratory network. And our overall goal is to integrate services, both on the diagnostic side and the treatment and care side, to ensure that patients have access to testing, access to care, and that this can be done well across disease areas. Factors to keep in mind are on the left, such as sample transport, supply chain and procurement, data connectivity, quality assurance, and human resources. Thank you for your time today.
You're on mute, George.
Sorry. Sorry. So I said before I hand over to my co-chair, I just want to remind everyone that the chat room is open. So please put in your questions as much as possible. There'll be time to go through and respond to them. More comments, questions, and concerns should all be in the chat room as for now. Over to my co-chair.
Thank you, George. Our next presenter will share with us priorities of diagnostic integration from the Integrated Diagnostic Consortium, that is the IDC. IDC is a group of major donors and procuring countries, implementing partners and technical agencies that aims to enable better coordinated procurement and deployment of platform-based diagnostic technologies to support HIV, TB, HPV, and hepatitis testing scale-up. Our presenter is Paolo Maggiore. I'm sorry, I may be pronouncing it incorrectly. Paolo is a director at the Clinton Health Access Initiative. Over to you, Paolo.
Yeah, thanks very much, Eileen, and thanks to ASLM for organizing this session. Just to make sure that my audio comes through okay, Eileen?
Yes, thank you.
Okay, fantastic. So I would like to start with a question, a point to reflect on. If you go to the next slide, what would have happened without integration? Where would a COVID-19 be today if countries had to set up ad hoc systems and capacity to put in place a testing response? I don't have a quantitative answer to this question, but I think we all would agree that we would have many more deaths today. And as you see from the slide, from the graph on the left side, in a very short time, LMICs have run almost 400 million PCR tests on both closed and open systems. And we know the logistics and supply constraints. And to note is also, in particular, how quickly the automated test was activated as soon as the assays had obtained UL. So the growth enabled by integration was quite impressive. If you move to the second slide, we can see that when the pandemic started, there was and there is still a very extensive molecular testing platform in place that was built over the past several years to support multiple disease areas, including HIV, TB, and now in minor parts by growing the FC, cervical cancer, and others. And this platform included more than 15,000 instruments globally and have a capacity to run more than 13 million tests per week across centralized, decentralized, open and closed systems. Now, if we move on to the next slide, this recent COVID-19 experience has been quite successful and showed us how fast and effectively integration could be activated. But we cannot say this has happened with other pandemics. If you think about HIV or hepatitis or HPV, which have been benefiting from integration, but in much lower scale and at much lower pace so far. So that said, we have observed an evolution of the molecular marketplace over the past years as it's become more integrated as a result of both supply side and demand side factors. So on the supply side, as Robert mentioned, there are several technologies that are both lab-based and point-of-care assays that currently exist to diagnose and monitor multiple diseases. And it includes HIV, TB, Hep C, HPV, and other STIs, even beyond this list that is shown here. And so on the other hand, countries have established networks that are more and more integrated, enabling integration, referral and testing across EID load at first, then between HIV and TB, and more recently adding other assays as well, including HCV and HPV. And currently, there are more than 50 countries that use multiplexing solutions to test more than one assay. But this evolution of the network has not always been as fast and as extensive as the benefits of integration would suggest. So we expect a much greater effort from all stakeholders involved. Now, if you move on, Eileen, to the next slide, I think by now, and it was mentioned by Robert just now, we're all familiar with the significant benefits that exist associated with integration, both on the supply and on the demand side, that make integration convenient. Primarily for manufacturers, could be about leveraging economies of scale and capital investments to reduce cost of production and service in the market. And for countries, the main incentive is access, as integration opens up more access points, service points, and efficiency, because cross-cutting systems can be shared across diseases. For these reasons, all the major global partners endorse and support integration. And if we move on to the next slide, we can see that this is well reflected by the scope and principles of the Integrated Diagnostics Consortium, IDC. On the supply side, IDC engage with suppliers to negotiate more inclusive and affordable offerings, leveraging more integrated testing. On the demand side, IDC support investments to create more integrated and efficient diagnostic network, and we will see a little bit more about it later on in the presentation. Now, if we just take a look at our supply side engagement through IDC and why integration is leveraged, if you move on to the next slide, integrated testing does facilitate the negotiation of more inclusive and lower pricing deals with the suppliers, because integration allows suppliers to generate synergies when manufacturing and selling different assets on the same platforms, and they can also share the service and maintenance costs across assets. So ultimately, this reduced cost can be passed down to the buyer. It can be an MOH, procurement agents, donors, etc. And here are a number of examples where integration contributed to make this possible, to make offering possible. If you think, for example, that MPMA for Abbott or the GX16 for Cephas, which are offered with an all-inclusive pricing model that can be accessed when activating integration. So we need to add viral loads to EID testing for MPMA to be able to access the all-inclusive pricing deals, and all molecular assays should be run on, or part of them, beyond TB should be run on Expert to be able to access the all-inclusive pricing offer that is activated on the GX16. So other pricing are also accessible across multiple assays, including Hologic, all-inclusive, and Roche pricing. So the integration has facilitated discussions and negotiations and offering on the supply side.
No.
But also on the demand side, if you move on to the next slide, the integration enables the sharing of the system. If you can move on to the next slide. The integration enables sharing of the systems and the operational cost across programs, which result in efficiencies and savings. A number of fixed costs can be shared across programs to reduce the overall cost per test, including, as we can see, instruments, service and maintenance, training, HR, data management, etc. And in a country like Zimbabwe, the TB program can save up to $1 million per year if 90 GeneXpert instruments are shared across HIV and TB. And this is thanks to the split of the operational cost between the two programs. And that experience showed also that utilization can increase within the optimal utilization rate that is set at 8% per instrument without disrupting TB services at the sites where integration was enabled. Now, despite all these benefits on the supply side and demand side, the adoption and expansion of integration has not been as fast as we all hoped for. And what we can do then to accelerate this process and do it right. So if you can move on to the last slide. And the first solution that comes to mind is the diagnostics network optimization, which is an exercise that really could help identify opportunity for targeted integration. And for the diagnostic systems or components of the diagnostic system by assessing demand and capacity available or required at each lab or health facilities. DNO have allowed countries to identify the sites where integration is feasible and generate the greatest impact, as well as those systems that should be shared across programs like the referral network, for example. Now, in addition to adopting or expanding DNO, where possible, we might want to assess the feasibility and opportunity to expand integration of TB testing on platforms beyond GeneXpert. There are several conventional platforms that, for example, have TB assay available, and there are several questions that should be answered, including if it's possible to use the same conventional instrument for molecular test and TB, how integration would work from an operational standpoint, and where it makes sense to enable this capacity. So there is evidence to be generated to kind of inform the expansion of integration, even beyond GeneXpert has been the platform that has been most utilized across HIV and TB, for example. And lastly, funding can also play a very important role to incentivize integration with cross-cutting funding and a joint accountability across diseases. So we know all the main donors by now are supporting integration, and they've also designed that funding streams to be accessed by multiple programs. The question is whether there is space for improvements on how this funding can be accessed and how countries can be made accountable when receiving cross-cutting funding. And this might be helpful to discuss during the next panel discussion. I'll stop here. Thank you.
thank you so much to the past two presenters who have shared an overview perspectives of diagnostic integration with institutional overview from WHO to CHAI. Paolo, who is speaking on behalf of the Integrated Diagnostic Consortium, they've taken us through the big picture, looking at what it takes for this to happen, looking at the tools, talking about some of the key platforms that have been upgraded to provide these services, and also the benefits of diagnostic integration. It is time for us to really... Hello, it is time for us to... Yeah, I hope this is resolved. It's time for us to begin to see this as something that is possible and feasible. We've seen data from a couple of countries showing that if you do this and do it right, it doesn't impact any other disease. Instead, it leads to, of course, overall test improvement, quality of tests, and release of results. So I think we have a lot of information at this point. We would be transitioning to key country examples to see how this has happened. And we have two countries, Burkina Faso and Tanzania. So let's start with our colleague from Burkina Faso, Adjima Kumbari, who serves as the national coordinator of the TB program in Burkina Faso. So Adjima Kumbari, over to you.
Hello. I can see my screen for Tanzania.
Please, we need the Burkina Faso presentation.
Oui, je suis connecté, mais c'est la voix qui ne passe pas. Oui, oui. Ils affichent la présentation, non? Que j'ai envoyée.
Oui, il va faire ça.
Tanzanie qu'on voit ça. Tanzanie qu'on voit.
Il va changer ça.
Bon.
C'est affiché, tu peux parler maintenant.
Alors, bonjour chers tous. Vous m'entendez?
Oui.
Ben, au prix de beaucoup d'efforts, je suis content d'être là pour partager au nom de tous les collègues du programme national de lutte contre la tuberculose du Burkina Faso et également de toutes les parties prenantes à cet effort d'intégration, que ce soit au niveau tuberculose, au niveau VIH, au niveau Covid et bien d'autres également. Voilà, la présentation, en tout cas, a été préparée par moi-même, M. Sawargo Léon, qui est le responsable du laboratoire national de référence des mycobactéries, et également l'un des TBM, M. Nebié Bayema, qui a été vraiment également au four au moulin sur le terrain pendant, en tout cas, les étapes pratiques d'intégration. Donc, nous sommes contents d'être là. On va partager l'expérience que nous avons pour le pays en matière à travers le PNT. Slide, s'il vous plaît. Alors, le plan que nous vous proposons, c'est de présenter un contexte après avoir introduit et de donner quelques points forts en termes de planification, de mission d'installation proprement dite et également de suivi et évaluation. C'est important, nous avons jugé important de pouvoir montrer à ce jour quand même la cartographie des analyses effectuées de façon intégrée. Il ne manque pas de défis, c'est ce que nous avons proposé de pouvoir présenter également. Et avant de conclure, nous allons dire un mot de perspective, toujours dans cette question d'intégration. Diapositive, slide. En guise d'introduction, on voudrait quand même relever le fait que, vous savez, la plateforme d'Inexpert, ça fait maintenant plus d'une décennie qu'elle est disponible. Et ce qui est bien, c'est que c'est vraiment un outil biomoléculaire qui sert à des fins diagnostiques et pour plusieurs maladies à la fois. Nous citons tout simplement la tuberculose. Et quand on parle de tuberculose, également la tuberculose pharmacorésistante, puisque ça permet de posé diagnostic de la tuberculose, résistante à la rifampicine. Et également, pour ce qui est de VIH, c'est ce qui est important, c'est le diagnostic précoce chez les enfants, les nourrissons, mais également la charge virale. Et également, le papillomavirus, et également tout récemment avec, en tout cas, le défi de la pandémie à COVID-19. Il s'agit d'un outil qui est vraiment utilisable en périphérie, ce qui est une très bonne chose. Et donc, cela favorise effectivement, en tout cas, la décentralisation dont nous avons besoin. Et c'est un outil qui minimise, en tout cas, qui permet de réduire au mieux possible, effectivement, le délai de rendu des résultats, ce qui est une très bonne chose, et pour le patient, et pour également les prestataires. Et vous savez que, en tout cas, au fil des années, avec le contexte tant international que national, en tout cas, il y a une rareté des ressources financières et tout ce qui peut être effectivement plateforme diagnostic notamment pour permettre effectivement d'intégrer les sources, les ressources. Et donc, en tout cas, elle est la bienvenue et c'est le cas justement de cette plateforme d'Inexpert. Ce qui fait que le pays, en tout cas, a retenu qu'il est important qu'on puisse saisir l'opportunité pour optimiser effectivement le test d'Inexpert au profit de plusieurs maladies. Et cette, en tout cas, conférence a retenu de parler de la tuberculose, du VIH et de la COVID-19 en termes d'intégration, mais nous savons qu'il y a bien d'autres maladies également que nous avons intégrées à ce jour, mais pour cette fois-ci, nous parlons de tuberculose, VIH et de COVID-19. Diapositive. Le contexte du pays, c'est lequel? C'est que c'est un pays d'Afrique de l'Ouest. Nous sommes en gros à 21,5 millions d'habitants en 2020. Et le système de santé tel que nous sommes à 13 régions sanitaires, 70 districts sanitaires. Les districts sanitaires sont, dans notre contexte, le lieu où se trouve effectivement, c'est le niveau opérationnel. Là où effectivement il y a les patients et là où effectivement on a besoin de plus effectivement d'efforts pour aller effectivement, en tout cas, à la couverture des besoins. Sur le plan hospitalo-universitaire, nous avons 6 CHU, 10 CHR, 45 hôpitaux de district, anciennement appelés des CMA, centres médicaux avec interne chirurgicale, qui sont maintenant des hôpitaux de district, 63 centres médicaux et il y a des formations sanitaires périphériques, ceux qui sont au niveau du premier échelon, donc qui sont au contact le plus proche possible du patient, et il y en a 1896. Sur le plan tuberculose, nous avons un laboratoire national de référence des mycobactéries. C'est vraiment lui qui organise, en tout cas, l'effort de diagnostic au plan national, en utilisant vraiment au mieux possible, dans le cadre d'un réseau, tous les laboratoires qui interviennent dans la lutte contre la tuberculose et en pleine collaboration également avec les autres LNR et avec la DLBLM, la direction des laboratoires pour la biologie médicale. Ce LNR est appuyé par un laboratoire supranational de référence. Vous savez que l'organisation, même depuis l'OMS, est telle que là où il y a des laboratoires nationaux de référence pour la mycobactérie, il est bon qu'ils soient rattachés à un labo supranational. Et dans notre cas, c'est celui de Milan depuis plusieurs années et depuis 3 années maintenant, celui de Cotonou, qui nous appuie pour effectivement faire apporter leur expertise pour qu'effectivement notre LNR effectivement soit toujours au rendez-vous des défis. Sur le plan d'Inexpert, puisque c'est surtout cela qui nous intéresse dans le cadre de cette présentation, nous avons, je vais dire qu'on a 31 d'Inexpert installés dans 29 sites. C'est écrit 29 sites, mais il y a 31 d'Inexpert installés dans 29 sites. Et les 29 sites là sont répartis sur l'ensemble des 13 régions sanitaires. Donc, il y a par région, on a 1, 2 ou 3 sites d'Inexpert. Ce qui est important également, c'est que sur le plan VIH, il y a un référentiel important qu'il convient de citer ici. C'est le cadre stratégique national VIH 2021-2025, qui est vraiment un document référentiel, en tout cas parmi les référentiels. Et également sur le plan tuberculose, nous avons le plan stratégique national de lutte contre la tuberculose 2021-2025, qui trace vraiment, en tout cas, nos interventions, nos stratégies, les activités effectivement en matière, y compris pour ce qui est du volet diagnostic, notamment par le Inexpert. Et également, le pays dispose d'un plan de prévention et de riposte à la pandémie, à la COVID-19, secteur santé. Et enfin, j'aimerais dire qu'on est dans la dynamique, effectivement, de la décentralisation du dépistage, de la prise en charge. Cela vaut pour la tuberculose, vaut pour le VIH et vaut également pour la COVID-19 depuis 2020. Donc, il y a cet effort de décentralisation qui se fait pour rapprocher effectivement l'accès au diagnostic aux populations. Diapositive. Au titre contextuel, c'est la dernière dia du contexte. C'est pour dire rappeler tout simplement ce que tout le monde sait, c'est que la tuberculose et le VIH, pour ne citer que ces deux-là, ce sont des cibles d'élimination des Nations Unies. Donc, à l'échelon 2030, ce qui veut dire que on peut dire dans moins de 9 ans, effectivement, en tout cas, ces maladies-là figurent au titre des maladies à éliminer. Ce qui est retenu effectivement par les Nations Unies et donc retenu par les pays, retenu par l'OMS, retenu par l'ONU-SIDA également. Nous ne pouvons pas ne pas citer le niveau de prévalence du VIH actuellement qui est à 0,7, donc on est à moins de 1% au niveau de la population générale. Les défis sur les 3,95 sont toujours là, que ce soit le premier 95 relativement à la connaissance du statut VIH, le deuxième 95 relativement aux ARV, le troisième 95 relativement à la charge virale indétectable. Ce sont des défis qui sont encore là et nous pensons qu'en tout cas la contribution de l'intégration va contribuer effectivement à relever au mieux possible ces défis. Sur le plan tuberculose, le dernier rapport de l'OMS qui est sorti en octobre 2021 montre que sur le plan incident de la tuberculose, nous sommes à 46 cas pour 100 000 habitants. Et quand on regarde les choses comme ça, cela permet de dire qu'il y a des gaps de notification, tant pour la pharmacosensible, qui est à 37%, que la pharmacorésistante, où le gap est à 65%. On parle de cela parce que le GeneXpert, effectivement, vous savez, permet de poser diagnostic la tuberculose et va plus loin pour dire également est-ce que ce bacille est résistant ou pas à la rifampicine. Donc ça, c'est important si on arrive à utiliser au mieux possible la plateforme GeneXpert pour aller vers la réduction des gaps de notification. Et enfin, vous savez que la pandémie à COVID-19 en tout cas, est toujours une réalité. Beaucoup d'efforts ont été faits et donc beaucoup de choses ont bougé. L'épidémie a connu en tout cas une tendance en tout cas assez favorable, mais elle demeure un défi parce que nous devons effectivement arriver à faire en sorte que la maladie soit éradiquée au mieux possible. Diapositive. Alors, sur le plan maintenant, comment est-ce qu'on s'est organisé pour arriver à l'intégration? C'est ça qu'on a appelé tout simplement procédure d'intégration. Je voudrais rappeler tout simplement que le programme tuberculose a vu cela de très loin parce que déjà dans les années 2013, nous avons travaillé à ce que les partenaires puissent nous permettre d'avoir un GeneXpert. Dès 2013, effectivement, on en a eu pour le laboratoire national de référence des mycobactéries. Et 2 années après, on a pu encore négocier auprès des partenaires pour avoir 2 autres GeneXperts. Et à partir de 2016, on a connu une certaine envol avec en tout cas l'apport du Fonds mondial qui a du coup, en octobre 2016, permis d'acquérir 12 nouveaux GeneXperts pour en tout cas améliorer la couverture du pays. Et en 2019, 4 nouveaux et en 2020, 12 niveaux GeneXpert, ce qui fait qu'effectivement, nous avons les 31 GeneXperts que nous avons travaillé effectivement à déployer sur l'ensemble des 13 régions sanitaires. Donc, c'est vraiment une planification rigoureuse qui a été faite. Nous avons pour cela un plan d'extension des GeneXperts. C'est ça qui est affiché à droite. Il n'est peut-être pas très visible. C'est un plan qui a été élaboré depuis bien avant 2013 pour voir comment est-ce qu'on procède effectivement à l'extension. Mais nous avons mis au cœur de cette extension également la nécessité qu'il se soit des actions concertées. Concertées entre programme tuberculose, entre la direction des laboratoires de biologie médicale. Vous savez que c'est la DLBM qui est vraiment la tutelle au sein du ministère de la Santé pour les questions effectivement de laboratoire biomédical, mais également avec le SPCNLS, Conseil national de lutte contre le sida et les IST, avec le programme VIH qui est le PCSLS-IST, et bien entendu, dans le cadre de la pandémie à COVID-19, avec le CORUS. Et comment est-ce que nous avons réfléchi pour dire que tel site, il faut installer le GeneXpert ou pas? C'est sur la base d'arguments épidémiologiques, également la base d'arguments géographiques pour tenir compte également des distances, également sur la base du niveau de soins. Voilà, quand on parle de l'hôpital de district vers l'hôpital régional, vers le CHU, on en a tenu compte. Vous allez voir, par exemple, actuellement, tout ce qui est hôpital, effectivement, et notamment les hôpitaux régionaux, ils sont couverts. Et les CHU sont en train d'être couverts également. Donc, ça a été une démarche qui a voulu vraiment être progressive. Le deuxième document que nous avons affiché à côté pour dire que dès qu'on a élaboré le plan d'extension de GeneXpert, en même temps également, nous avons défini ce qu'on a appelé plan de gestion des cartouches, parce qu'on savait que ça allait être une question critique. Il faut que les cartouches soient disponibles. Donc, cela a été défini et même dans ce plan de gestion des cartouches, les questions effectivement de comment minimiser les erreurs effectivement de diagnostic par le test COVID, par le test d'INExpert étaient déjà définies à ce niveau-là. Diapositive, s'il vous plaît. Alors, nous avons, sous l'égide de la direction des laboratoires de biologie médicale, participé à l'animation d'un groupe technique qui a été mis en place pour voir comment est-ce qu'on optimisait effectivement, en tout cas, l'utilisation des GeneXpert au profit de plusieurs maladies, dont la tuberculose, dont le VIH, dont la COVID-19, dont même les autres problèmes de santé tels que papillomavirus également. Et l'expertise du LNR mycobactéries a été reconnue et surtout a été utilisée dans le cadre de cette intégration. Déjà par le choix des sites, parce qu'on avait une expérience effectivement de comment est-ce qu'on y allait pour choisir les sites. Également sur le plan évaluation de la capacité des sites qui ont été choisis pour l'intégration. Donc l'expertise du LNR a été mise en avant pour cela. Également, tout ce qui est correction des insuffisances également, en tout cas des sites évalués, puisqu'il y a eu un travail effectivement d'évaluation qui a été fait avec une identification des insuffisances, que ce soit des insuffisances tout sur le plan purement paillasse ou bien des insuffisances également sur le plan organisationnel pour que les GeneXpert soient utilisés de façon optimale. Diapositive. Et pour être très concret également, il y a eu des missions de maintenance des plateformes. Et, en tout cas, ça par exemple, c'est un exemple d'un site où effectivement, en tout cas, des séances effectivement de maintenance ont été faites. Vous savez que pour le GeneXpert, quand on parle même de maintenance, la maintenance préventive est très importante, puisque normalement, on doit avoir effectivement des actes de maintenance au quotidien, de maintenance hebdomadaire, de maintenance mensuelle et enfin également même de calibration annuelle. Donc ça, c'est très important sur le plan même préventif. Et après, maintenant, pour ce qui est du curatif, on travaille en pleine collaboration avec CFED, siège ou bien son représentant. Diapositive. C'est pour dire également que toujours dans le processus d'intégration, l'expertise du LNR est allée également sur les missions de paramétrage. Vous savez, quand le GeneXpert arrive, même quand on dit qu'il peut être utilisé pour plusieurs maladies, il est bon qu'on passe par une étape importante. Et cette étape importante, c'est quoi? C'est le paramétrage. Pour qu'effectivement, on puisse utiliser une maladie qui n'était pas forcément dont le paramétrage n'était pas fait. Donc, on puisse effectivement faire cela et ensuite, les modules qui sont là peuvent être tout simplement utilisés pour poser le diagnostic. Donc, cela a été fait et le LNR a pu effectivement conduire ces missions-là. Également, la formation des acteurs. Vous savez que ce soit... Oui?
I'm sorry to interrupt. Can you speed up a little bit because we're running behind time? Thank you, presenter.
OK, thanks. Donc, sur le plan formation également, le LNR, en tout cas, a beaucoup participé à la formation, en tout cas, des acteurs sur le terrain. Diapositive, s'il vous plaît. Alors, c'est pour dire également que tout ça, c'est la suite des formations avec des images qui sont affichées, que ce soit des formations faites sur le site, quand il s'agit, par exemple, de COVID-19 pour aller vite, et également des regroupements qui ont été faits au niveau central, notamment à Ouagadougou. Ces formations ont été faites. Diapositive. Slide. Alors, c'est pour dire également que pour accompagner cela, on a sorti des directives pour montrer, par exemple, on était conscient qu'il peut y avoir effectivement une charge de travail importante. Et donc, dans ce cas de figure, on a guidé quand même les praticiens sur le terrain pour montrer, lorsqu'il y a plusieurs échantillons qui arrivent à la fois, quel peut être l'ordre d'utilisation de ces échantillons, en positionnant la COVID-19 comme étant la priorité numéro 1, et ensuite la TB, et ensuite diagnostic VIH, charge virale. Si cela est nécessaire, même, on avait dit que le diagnostic de la tuberculose pouvait se faire même pendant la garde. Et nous voulons mentionner qu'il n'y a pas eu que seulement la formation, il y a eu la supervision également. Diapositive. Voici la dia qui montre que sur les 29 sites GeneXpert, il y a 22, soit 76%, qui ont effectivement l'intégration actuellement. Tuberculose plus VIH, il y a 4 sites. Tuberculose plus COVID-19, voici les sites qui sont là. Et tuberculose, VIH et COVID-19, Il y a également 5 sites qui sont là, au total 22 sites sur les 29. Diapositive. Il y a des défis, comme cela est souvent le cas, c'est que c'est la disponibilité des cartouches. Cela a été relevé déjà par plusieurs missions sur le terrain. C'est la disponibilité également en courant électrique continu et en température optimale. Il y a également que la question du transport d'échantillons, on va dire dans le contexte des zones à déficit sécuritaire, est vraiment un défi important. Et l'épidémie à COVID-19 qui, effectivement, peut entraîner une surcharge effectivement, de travail sur le terrain. Donc, c'est des considérations à prendre en compte. Il y a également comment faire pour que, même quand il y a une surcharge de travail, que les agents soient toujours motivés à continuer à travailler. Et il y a bien entendu ce défi de gestion sur le plan maintenance et sur le plan fonctionnement. Nous terminons avec les perspectives. Perspective diapositive. Slide, s'il vous plaît. C'est juste en 2 points pour dire que ce n'est pas exhaustif, mais les 2 points importants, c'est pour dire qu'on compte évaluer, en tout cas, c'est test d'une experte. Nous n'avons pas encore mobilisé de financement pour cela. Donc, on va développer le plaidoyer qu'il faut pour, en tout cas, faire l'évaluation de ce que nous venons de présenter. Et également, on garde à l'esprit que nous voulons améliorer la couverture des besoins. Donc, cela passe également par l'extension des sites d'Inexpert pour qu'ils soient augmentés, que ce soit à travers les subventions de tuberculose, la subvention du Fonds mondial ou autres partenariats, que ce soit puisse augmenter, et en utilisant également les autres plateformes d'Inexpert qui sont déjà disponibles au travers d'autres portes d'entrée. Et enfin, diapositive, slide. C'est pour dire un mot de conclusion seulement, rappeler que, en tout cas, les ODD, les objectifs de développement durable, nous devons effectivement accélérer nos efforts pour leur atteinte. Il s'agit c'est dans 9 ans, 2030. Et personne ne doit être mis de côté. Et tous ceux qui ont besoin effectivement de tests TB, VIH, COVID-19, pour ne citer que cela, on peut ajouter papillomavirus pour le cancer du col de l'utérus également, doivent y avoir accès. Personne ne doit être mis de côté. C'est pour cela que nous devons effectivement déployer nos moyens et nous pensons que la plateforme d'Inexpert peut énormément contribuer à améliorer la couverture des besoins en vue d'aller vers la couverture universelle. Merci d'avoir prêté attention à notre modeste présentation qui a été faite au nom de plusieurs acteurs du pays. Merci beaucoup pour l'opportunité.
Thank you so much, Dr. Jima Kumbari, for that excellent presentation showing the impact of the use of GeneXpert in the context of integration in the Burkina Faso. As already mentioned by my co-chair, we are running behind time, so let's move to the next presentation from Tanzania. This is to be done by Agnes Wisi, I hope I can pronounce this well. This name work, Berje, who is also the coordinator of the Viral Load and Early Infant Diagnostics in the Ministry of Health of Tanzania. Over to you.
Thank you. Hope you can hear me.
Yes.
Thank you. I'm Anyelisia Kabuje, ASLM LabCoP country team. So I will take you through the experience of Tanzania on molecular diagnostic integration. Next slide. Yes, this is the Valid and DID scale-up milestone in country. So in 2015, we adopted the WHO guideline for valid monitoring for ALT clients, and come in 2016, we started routine viral load monitoring for clients who were using ALT, and in 2017, we accelerated the viral load testing scale-up through increasing the new viral load PCR labs and optimizing capacity which were available in the country. And in 2018 is whereby we started doing monitoring of viral load scale-up program. So through this one, we had no way but to do a thorough assessment of our entire cascade in viral load scale-up through using the diagnostic network optimization exercise. And coming 20 to 2021, we were implementing the recommendation from the diagnostic network optimization. Next slide. Here is the DNO aimed at providing solution to existing challenges in Valid scale-up program by optimizing testing demand and capacity in the most cost-effective way. So why did
We lost you.
we decide that one? Looking at
Hello, we're not getting you. We are not getting you.
It seems our presenter is having audio problems or internet problems. Please bear with us.
hello, can you hear me now?
Yes.
Yes, apology for connectivity. I was saying that in DNO, when why did we do DNO? We looked at our program. Coverage for Valid come in FY 2018. We came to realize that the country had enough testing capacity, but what we actually achieved, coverage, we only reached up to 75% coverage. So as a country, we decided to do intensive diagnostic network optimization exercise through looking on the entire Valid cascade, and we used a tool. It was a tool which had a capacity to identify area for improvement in our VRO program. So we did this one in 2018 to 2019. Next slide. Then after DNO exercise, these were some of the achievements from the recommendation on the diagnostic network optimization, specifically in molecular testing. So as a country, we managed to integrate TB, HIV, Valid, and EID testing using the near point of care technology, which is GeneXpert we are using in country in high volume sites by focusing on the pregnant women, breastfeeding women, children, and those who required second test after high Valid. And also we managed to decentralize COVID testing by using conventional Valid testing platform across the country, in all zones. And also we came to interface CTC2 database and the laboratory testing database, which are now communicating together using the unique ID for client across the country. Also, we came to develop the national guideline for sample referral system. This guideline was actually covering how we will be transporting TB and HIV. In 2019, the guideline was authorized by Permanent Secretary. But again, we developed our Valid dashboard and web-based active portal for mapping all hub and spoke, and the dashboard, Vero dashboard was used to visualize the monitoring of testing and the other activities going in the lab. But also at the end, we, as a country, we wanted to have a comprehensive integrated sample referral system. So with the guideline which we prepared earlier in 2019 was lacking as a type of test. So we decided to develop a procedure manual, which was comprehensive, covering all types of samples. But as a country, we started with few type of sample, which we actually integrated with the hub and spoke model and the support of Valid package. So we are currently using the same transport model for TB, HIV Valid, EID samples, and the COVID sample and drug-resistant samples. So the same sample transport system actually covering all things using the by leveraging the support from Valid testing. Next slide. Yes, this is the geographical landscape for our country, showing the 4 zones in the country with conventional technology. So looking with the orange dot, it shows the location of testing laboratory with conventional platform doing both Valid and EID testing. Again, with the black dot, it shows the Valid lab, which testing lab doing only Valid. But come to each 4 zones had been equipped with at least more than 2 testing lab doing both Valid and EID. And it is the same equipment we had so far integrated with COVID testing. So in our country, both zones, you can access COVID-19 testing after we did this integration. So next slide. Yes, come to point of care, which we actually refer here for gene expert. We adopted the COP guidance on ensuring we do integrating this molecular testing. So with the green dot shows the location of testing lab, testing facility doing Valid and TB. Again, with the light blue, you can see the lab doing EID and TB, and deep blue, it shows the lab facility which are doing TB, EID, and Valid. So with this multiplex implementation, we actually succeeded to be able to at least reach and test all early infant diagnosis testing for new baby born below 2 months from the base. Next slide. Yes, this is also showing the cascade of impact of diagnostic network optimization, looking at the Valid coverage. So looking at the line of black line, show the VLO suppression from coming 2017 to 2021. We had 84 suppression rate up to 97% of suppression rate by Q4 of 2021. So this was a great achievement. But looking at the VLO coverage, in 2017 we had increased, we had low VLO coverage from 35% to 86% by 2019, but there were a small decline from 86% to 72% VLO coverage, and then to 2021 the coverage had raised. I think the main cause of decline of this VLO coverage was affected by the pandemic COVID-19, which had disturbed the system which were put on place. But looking at the brown bar, it shows the number of testing labs. So by 2017 we had 16 testing labs, but up to 2021 Q4 we had a total of 43 testing labs. So at the country we also had improved the capacity by increasing number of platforms. The same applied to light blue bar showing number of showing number of platform. So I think I confused the colors. The brown was showing the number of labs, while the blue showing the number of platforms. So the number of platforms was 18 to 43 up to 2021, while the number of testing lab by 2017 we had 16 testing lab. Up to now we had 23 testing lab. So these utilization of DNO recommendation and other intervention had led us to the improvement of these testing, as I have said before in the previous slide. Next. But still we have some challenges in our molecular techniques integration system. These are so far affected by reagent availability, and we experienced much more during COVID pandemics. But we have also suboptimal capacity utilization in the testing lab. As I have presented, we have more than enough testing capacity, but there is suboptimal utilization. Also, we have inadequate demand creation, and we lack electronic system to notify clients that their results are available at the clinic. So we have no text message to the client. But also we have suboptimal implementation of DNO recommendation. And these are some of the way forward. For the reagent availability, we are now working on improved forecasting and supply chain planning. But also in suboptimal capacity utilization, we are insisting on the diagnostic network optimization to utilize whatever we can in a multiplex way to ensure that we provide results on time and we utilize to its optimal. Also on the inadequate demand, we are still moving forward on sensitizing the lab and clinic interface, which bring people together to ensure that they collaboratively solve problems regarding on the and increase VLO coverage. Also on the issue for client notification, we are now developing client-centered strategies to inform the client of whatever services are available to the clinic, especially having a system which will be notifying them to come back to the clinic. And on the implementation of lab optimization, we are working on strengthening coordination among MOH, stakeholders, and donors, together with partners, so that whatever had been recommended, we identify a responsible person to implement the recommendation so that we can optimize our VLO testing services in the country. So next slide. So thank you. Having said that, I have no more to say, but this is the experience how we had implemented a multiplex in a molecular testing in Valod and EID together with COVID and the other diseases, which we are continuing integrating them. Thank you so much.
Thank you so much for that excellent second country example from Tanzania. We're literally running out of time, so an observation here is that we will not be able to take questions. At the end of the presentation, there are already some questions in the chat, so we encourage the presenters to read and respond accordingly. So let's quickly listen to the last presenter, who is Dr. Collins Otieno Odiabo, who serves as the project lead for the Laboratory System Strengthening Community of Practice project for the ASLM. So Dr. Collins, over to you, and we hope you can be as quick as possible. Over.
I'll try. Thank you. So please load up my slides. So I will give you a summary of our visit in 7 LabCoP countries. 2 countries have already presented. So I'll give a landscape of diagnostic integration among 7 countries. Next slide. Yeah, so just to highlight that the Maputo Declaration calls on the countries to unify laboratory networks to support laboratory services for the major.
Can you be a little bit more audible? We are not hearing well. Maybe move closer to your mic.
Can you hear me better?
Yes.
Okay. So just to call out that the Maputo Declaration talks about unifying lab networks to support the major public health diseases. Here, test integration refers to multiple testing on single platforms. And we have already learned from the previous presentations that test integration can improve access to services using existing investments. There can be more efficient use of the dwindling health system resources. And in other words, we can do more using less. Next slide. Yeah, so Robert already showed this, so I won't dwell much. All we know is that the landscape of diagnostics has these molecular platforms that can test more than one virus. And as such, there's an opportunity to integrate on that, including the recent COVID-19. Next. Yeah, so we need to, we know that there's a good footprint of TB platforms and that it is underutilized. So this makes it a good candidate for integration of additional tests, including HIV and COVID-19. And as such, it is important that countries that have started implementing integration of these diseases share these experiences. Secondly, as been demonstrated by the previous speakers, there are benefits to integration, including reducing the turnaround time for HIV tests, decreasing programmatic costs, and there's generally good acceptability. However, we need good M&E to be able to capture these good demonstrated factors. However, there are challenges, and these still need good M&E to capture. We need to adapt clear workflow in the laboratory. We need to take care of workforce to ensure that we increase their numbers, to train them on these new technologies, among other things. More importantly, we need to ensure that we have data so that we don't overuse this equipment. And lastly, we need to respect those specific testing packages. So it is important that we have good practical guidelines and national strategies to ensure that these challenges are addressed. Next slide. So in June of 2020, LabCoP conducted a survey among 14 LabCoP countries to find out what the effect of COVID-19 had affected viral load and EID. In addition, we asked the countries what kind of support they would want from ASLM. And 8 countries responded in this front about integration, and mainly countries requested technical guidelines on how to incorporate COVID-19 into testing using the current platforms. They also asked for best practices from countries that are already integrating HIV, TB, and COVID-19. They also wanted to know how they would be able to incorporate COVID-19 without eroding the gains that have been made in EID and viral load. They also asked of what strategies they could use to improve the implementation or use case, and also which diseases can be prioritized for diagnostic integration. Next. So we, in between June and November this year, the LabCoP team was able to visit 7 countries, as shown on the map there. We visited Sierra Leone, Burkina Faso, Nigeria, South Sudan, Tanzania, Burundi, and Eswatini. And as you can see, the traveling from the East of Southern Africa to West Africa is very long, and also you need some time to go onto water transport. Next. So the scope of the visit was to learn the integration use case, to do a scoping of the stakeholders who are involved in integration, also review national and institutional policy and regulations that support integration, if any, and finally to survey some implementation considerations. The whole idea was to identify best practices, gaps, and opportunities for improvement. Next slide. So I'll give you a summary of the findings. Next slide. So in terms of integration use case, we were able to get information from 6 of the 7 countries. As in Sierra Leone, the equipment had broken down, so testing was not going on. But as you can see, in terms of the scope of integration, almost all countries are integrating some HIV and TB, but others were able to go ahead and even add COVID-19, Ebola, and HPV. The main platforms that were being used at decentralized sites were gene experts, and there were also centralized equipment like Hologic and the Roche that were being used. The model of implementation was mainly decentralized testing with some centralized testing in at least 2 of the countries, Eswatini and Nigeria. Next slide. So in terms
If you can move faster, that would be great, Collins.
Yes. So in terms of stakeholders, 6 of the 7 countries already have lab directorates, so that's a good entry point to start discussions on integration. In terms of technical working groups, some countries have already created these technical working groups involving individuals from different disease programs, implementing partners, and there are already meetings that were taking place in Burkina Faso, quarterly meetings, and in Tanzania biannually. Next slide. In terms of policy and regulation, we realized that the countries have national laboratory strategic plans, but these plans do not explicitly mention diagnostic integration as a strategic objective. There are also guidelines that are being developed in Burkina Faso, for multi-disease testing, and this was a recommendation from our LabMap project that was implemented there. 6 of the 7 countries had no national list of priority diseases, as you have heard in this meeting before, and only Nigeria has been able to develop a national essential diagnostic list. In terms of harmonization of equipment, the guidelines that are there are not yet based on possibilities for integration of services. Next slide. In terms of equipment, there was a wide fleet of equipment with the used and unused capacity regularly measured. For example, in Tanzania, there are 336 gene experts, but the utilization is just 49%. Only one of the 7 countries, which is Tanzania, indicated that all the 336 gene experts were already on maintenance contracting. In terms of informing the diagnostic strategy, most countries reported that they have a GIS or a paper-based map of medical laboratories, and this can feed into ongoing DNO exercise or planned exercises to inform the test integration use case. Nigeria and Tanzania have recently conducted DNO exercises, and Nigeria intend to do another one. Burkina Faso itself has a full GIS map of laboratory capacity through the LabMap project, and this will be used to inform integration towards addressing population coverage. Next slide. So in terms of supporting systems for integration, there were backup testing plans, but this was mainly for the HIV testing. As been mentioned by Tanzania already, there are countries that have integrated specimen referral systems. The challenge there was in terms of financing that plan by the different programs. Tanzania and Burkina Faso also developed a strategy on how to test when there are large volumes of samples. So it's whether to start with TB or COVID-19, and you can see that there. There were main issues in Nigeria TB program that mentioned that they do not support integration because certain issues that support integration need to be addressed upfront, like HR and also maintenance contracting. There were also challenges in terms of quality management system and accreditation of additional tests on equipment or in those labs. And the use of SLITA unofficially was very common in this country. Efforts to integrate results reporting was ongoing, but this was preliminary within the country. Next slide. So how do we measure the success of integration?
So
we
need do you see how many slides? And then we need to wrap this now. Do you see how many slides?
Yeah, maybe 4. I'm almost done, 2 minutes.
Okay.
So to better address integration, we need to monitor the population. the cost, the number of tests increases annually to be able to address those issues. In terms of M&E, we are aware that none of the countries was conducting M&E of integration routinely. Next slide. So as we conclude, we know that some countries have found solutions and good ideas in integration, and this provides a reference that countries can aspire to achieve. The solutions and considerations, we can summarize them in an integration readiness tool, and LabCoP can facilitate this measurement of success of integration as we do our annual self-assessment in the countries. Next slide. So LabCoP is proposing the development of a tool that has 3 capabilities and 7 components. Capability 1 is in preparation and planning, and that includes policies, governance, coordination, and funding, and test use case. Capability 2 is implementation, that includes network, supporting systems for integration, and technology. And capability 3 is performance, monitoring, and improvement. Next slide. So the tool will be a 4-coded scoring system ranging from 1 to 4, with the stage 1 in red referring to poorly defined processes, and the stage 4 is dark green, and that's where we aspire to be, which refers to processes that are well defined and continuously improved. Next slide. So the next steps are to define these steps that we have shown 1 to 4 using the capability maturation model, and then we will use the tool to assess progress in countries that are implementing integration. We will also plan to share best practices to optimize integration services and update our decision-making matrix for improvement of integration services. Next slide. So I'd like to acknowledge partners who are able to review the tool, including OGA, Child, CHI, and Global Fund, and the country teams, and also the ASLM LabCoP staff. Next slide. And I'd like to thank all the stakeholders, some of who have presented here. Thank you.
Thank you very much, presenters, for some very informative presentations. As mentioned, our resources are limited, and we must integrate to improve service delivery. We have to do more with less. We can see from the presentations that integration is gathering pace, but maybe not fast enough, because we've been talking integration for many years now. I think COVID has forced integration more on all of us, and the journey has begun, and we must continue. It's everybody's business. I hand over to my co-chair, George, for the rest of the session. Thank you.
Thank you so much, Eileen, and thanks to the presenters of the first session. We are moving to the second part of our 2 hours presentation, which is a panel discussion. We are really running out of time. I know our panelists have so much to share with us, and I'm very confident that we shall make use of time because these are seasoned experts in the field. So it's going to, again, as we said earlier, involve both stakeholders and diagnostic manufacturers, and they will be responding to a series of questions. Some were in the chat, and we did not pay more attention because we know in the course of this last section of the presentation, we will receive responses from our panelists. So I just want to take a minute to introduce them. I will be quick and short. We would have Francisco Marinucci, who is the Director of Global Markets Access at Abbott, where he focuses on strategy and business development related to access to molecular diagnostics for multiple infectious diseases in high-burden countries. We have, please, if you're not, you just have to mute. We have Jonathan Kilter, who leads the healthcare transformation team for Roche Diagnostics Management. We have Jesse Wambuga for Hologic. He serves at the Hologic Global Access Initiative Director and responsible for Hologic's business in Africa. We have Philippe Jacun, who is the Senior Vice President, Global Access. There is, I hope.
That's good.
Okay, let's move to, I have Temba Lamine, the program manager for the National TB Control Programs in Eswatini. And lastly, most importantly, of course, we have Smaika De Lucenye, who is the program manager at UNITE, managing UNITE's molecular diagnostics and cervical cancer portfolio. I think this is the base for the innovations. UNITE has funded a lot of studies showing the impact of integration. So great to have you all here. We will start with the very first question, which is directed to the industry. Our industry partners, you are a significant player in today's subject. I hope we have some of the major players on the continent panel today. My question goes to each one of you, and it will be in twofold. The very first one is, what are you doing, or what are plans to support diagnostic integration? That is number one. The second question is, what do you think the industry can do at large to facilitate multi-testing integration? So let's start with each of the diagnostic manufacturers. Let's start with Francisco. Over to you.
Thank you, George. Can you hear me?
Yes.
Thank you. So, I mean, very quickly, just to answer your two questions. I think what we are currently doing is to be present, right? So I think we are on the ground. We've been able to build, over the years, a very solid network on the ground, capable to provide, timely access to our service engineers, so to avoid, the instruments to be out of order. And this has been, very nicely translated and captured by our major funder, PEPFAR Chemonics, where we are able to meet the KPIs that are very stringent in terms of reagent stockouts, in terms of uptime of the instruments, and so forth. So I think we, as Abbott, we are very proud to be a major partner in this effort to strengthen diagnostic network optimization by being present on the ground with our teams, with our capacity to be able to timely support these efforts. In terms of what I think the manufacturer would like to do or would like to see in terms of diagnostic network optimization, is really, how we can come together to make sure that we have an understanding of the needs. Sometimes we are not in these roundtable discussions. Very often we are not invited in any meetings around integration where we can contribute, by sharing our experience, by sharing also our needs that sometimes are underestimated and not well understood by the global health players. Over to you. I want to leave space to the other speaker. Thank you, George.
Thank you so much. Before we move forward, I really want to encourage that if you are not speaking, please be on mute. There's a lot of behind the screen noise. So thank you all. Let's move to Felipe.
Yes, George, and good morning, everybody. It's a pleasure to be on this panel today. I'm not sure really what I can add after all the presentations I've heard earlier this morning, because I cannot think of any one of them that has not spoken about GeneXpert and how the GeneXpert has changed the landscape in many countries in terms of integration of testing. So to your questions, what we plan to do is really to continue and help countries to implement even more integrations in a new world where we are talking more and more about people-centric healthcare, which I think is the new name of the game these days. So it's really getting to make sure that when the person comes to somewhere to be for healthcare needs, it's not tested only for one disease, but for himself, right? And so can be tested for many different diseases. So this is testing integration, and this in the context of decentralization. Because I think it's understood also now that in order to be able to reach more of the people, we need to get more and more decentralized, which is what we've been able to demonstrate also with GeneXpert. So what we're doing to help is that on top of what has been done in many countries until now, in terms of utilizing the excess capacity that was existing on the GeneXpert that had been procured for TB and are now used for other diseases, is also to help by proposing new approaches, and I think Paolo mentioned that earlier, which is the all-inclusive GeneXpert 16 approach, for instance, which, if placed strategically in countries, will help get to these multi-testing capabilities, at point of services for people that will help fight all the diseases. And as was mentioned by Dr. Kombari before, we want to be fully part of reaching the SDG 2030 goals. So in a nutshell, this is what we're doing. Thank you for having us here, and thank you for the presenters for sharing their experiences with GeneXpert.
Thank you so much, Felipe. Let's transition to Jesse.
Thank you very much, George. Can you hear me?
Yes.
Excellent. So Hologic continues to be present in the markets, and we are firmly committed to the integration. One of the few things that I think we've been a market leader in is in the all-inclusive pricing, which means that if you buy our products, you're getting service, training, maintenance, spare parts under one price. There's no hidden costs. There are no costs for consumables, etc. In addition to that, our platforms have a broad assay menu. Just to name a few, the Panthers that are currently in Africa can run HIV, hepatitis B, hepatitis C, human papillomavirus, and most recently as well, SARS-CoV. And we've seen this being used in multiple countries where they're running HIV and SARS-CoV seamlessly, as well as HPV, all those three assays on the one platform. In addition to that, the automation of instruments is key to this, because it means that even during COVID pandemic, the training from a user who's doing HIV to add training for them for HPV. We've done this in countries remotely, which we've done just in half a day training. We're able to convert a user from just being an HIV viral load tester to actually HIV, SARS-CoV, and HPV tester through just an online training from half a day. So these are some of the things that I think we can do. There's a lot more I can say about efficiencies and how we're enabling that, but I'll pause here and let my other speakers go.
Thank you so much. Jonathan, over to you.
Hi, good morning, everyone. So I think from our perspective as Roche, we've been present on the continent now for several decades, working around molecular diagnostics, and we've in many respects helped a lot of programs build initial testing, and so we will continue to do this. So our chosen model is really to partner with countries and programs to really on one side understand the needs and then co-develop, co-create solutions in the lab and then beyond the lab. So some examples of this would be around we've looked a lot at sample transport, sample referral. More than 10 years ago, we helped PEPFAR and other agencies develop a dry blood spot for early infant diagnosis. Recently, we've launched a plasma separator card that allows you to create a dried plasma spot for viral load. We've also, and we have and continue to invest in digital tools for result return. For example, we have an app called Etemba Life, which allows us to return viral load results directly to the patient, which reduces loss to follow-up. Thinking of integration specifically, we run a team of healthcare consultants who are specifically trained actually on network optimization. And, for us, this is really key. I think there's many manufacturers represented here. We all have our solutions. We all have our opportunities. And for me, for programs, it's about how do we optimize all these investments that all of the different players are making in the market so that you have one single, really well-functioning diagnostic network that allows for centralized labs and decentralized labs that really optimize the patient experience. We've also just launched yesterday, actually, here at ASLM, our new Cobus 5800, which is a much smaller, fully automated molecular platform that will allow us to support, hopefully, some mid-sized labs. And, through our Global Access Program, which is about price, but it's also about capacity building, we can offer HIV, hepatitis B, C, HPV, NTB, COVID, and a whole variety of other new assays that are coming online. And really the idea here is, as I say, is to figure out how do we co-work. And I really want to pick up on what Francesco said earlier. We as the industry, I think we're all willing and open to collaborate more and to really spend time speaking to stakeholders and programs to make sure that we can help solve the big problems. I think one of the key asks from my side would be for programs to clearly define the goals that they have for integrated programs. That's always very, very helpful for us to then get on board and support you. But I think it's also about having a willingness to redesign. Some of the earlier presentations we saw showed this immense cost saving that happens when programs are integrated, but that is going to require some redesign. And I think as an industry, we're willing to support that, but it requires that intentionality from the programs to be willing to integrate.
Thank you so much, and thanks to our colleagues from the industry. We will now transition to a typical country example, really looking to tracking some of the barriers to integration. We do have our colleague from Eswatini, who is also in the process of implementing integrated testing on existing gene expert platforms. So the realization of integrated testing certainly require lots of systemic changes that bar challenges. Can you tell us a little about the challenges that have been or are likely to be encountered and how this can be overcome? Temba, over to you.
Thank you very much. Fortunately, a lot has been covered during the presentations. But obviously, Eswatini would like to go integration. We've already done a pilot where we have realized that we need to go integration because the evidence that we gathered from the pilot is that it is possible, and actually it will help improve service delivery because, for example, when I come to the issues, there's been issues around TB programs and HIV programs fearing or trying to protect their territories, where TB might think HIV want to cannibalize on their instruments, where HIV thinks TB wants to do the same. But now there's been a lot of collaboration in the country, having started in the TB HIV one-stop. But now we just need to move towards integration in terms of diagnostics. Like I've just said that we have just finished a pilot where we have agreed, and when we look at the issues, definitely it was just fear, but of course the conventional laboratory has been overstretched while not being able to meet the needs of the population. Whilst on the other side, we have realized that the gene aspect has not been fully utilized. So it has been underutilized. So it needs to be integrated so that it can facilitate the other tests. In Swaziland, we have a case like most countries where the integration has been further strengthened by accident during the COVID-19 epidemic, where the TB laboratory had to do the COVID test, and then we realized that we can integrate. Now, we think we should aim at facilitating more collaboration, which is already more on the ground in most countries. TB, HIV, and sexual reproductive health programs are working together, but they have to further do this at planning level from inception, so that they can realize that if we combine this, we integrate this testing, we will also realize some efficiencies, which can help countries in the already overstretched health delivery care systems, which are already overstretched. They can use one machine, we can use the same HR to do all these tests. So I think this is, in Eswatini, we have realized that this is going to be, the integration is the way to go, and evidence shows that it actually adds value for money than the opposite. Maybe I can stop there for now.
Thank you so much for that very, very brave and excellent contribution. We are moving to the funders. And we know funding is a key to all what we are talking about. And we have our colleague here, Smaika, who leads that aspect with Unity. So, Smaika, what investments have been put into diagnostic integration over the past decade? What should be the ideal future outlook for funding to sustainably facilitate testing integration at the national level? Over to you.
Thank you so much, George. And it's really a pleasure to be on the panel with so many important gentlemen in the world of diagnostics and the response. It is really, I think even just listening to all the presentations and also the panelists before me, we are boiling down to a couple of very important points. One of them is really the willingness to redesign, as Jonathan mentioned, and I really like that point, because as a funder of different molecular diagnostics over the past more than a decade, we did notice that despite the evidence, and Paolo presented it earlier, of this actually working and not working at the expense of any program and actually generating savings, that it has not been something that actually gained substantial traction in countries. We have seen that the evidence indicates that this is the way to go. Definitely, as Eileen mentioned, COVID, with its urgency, actually brought a lot of changes much faster than we managed to do it, even based on the evidence before. However, there are some systemic and structural issues that need to be resolved in order for this to actually really gain further traction in non-COVID times and post-COVID. First and foremost, and based on what you called me out to speak about, it is the funding streams and how actually the funding currently is designed for diagnostic capacity. We have seen that most of it is disease specific, and that we rarely see funding that is actually going towards diagnostic or laboratory capacity as such, which would avoid that kind of compartmentalized approach to diagnostic. The second thing is that there is that political will aspect, and we have seen that different disease programs, probably because of the emergency of the needs, are more or less keen to change or to redesign their capacity in order to accommodate other needs. We have just started some work on HPV testing, the cervical cancer part of the screening, and it is something that potentially can be integrated and actually even while analyzing the capacity in countries, you can notice that the capacity is sufficient to actually respond to the needs of different diseases, whether it's TB or HIV or HPV or HCV. But it's really around the political will to change, political will to maybe in some cases even reshuffle the network and redesign the network. We also have been supporting, and over the last 10 years, there has been kind of a development in how we understand the optimized networks. And that's also a very detailed and labor-intense process. So it is not something that happens overnight. Somebody on the panel, I don't remember who exactly mentioned really understanding the capacity and the needs. And this is something that is done in the context of the diagnostic network optimization, but it is a process that can take a lot of time. And then also, based on the results, it requires also a lot of investment in order to be implemented. So that's something that actually has to be supported by the funding that, again, cannot be prioritizing one disease or over the other. And finally, I wanted to say that I'm really impressed with the evolution on how manufacturers actually responded to our calls to look into integration and to look into their offers across the disease assays in a kind of holistic way, and some maybe faster than the others. We are still looking at bringing TB in the same kind of, there has been that kind of maybe unnecessary division between TB and virology that we can still bridge maybe, because this is something that would greatly help us also look at the volumes in the same way, look at the efficiencies in the same way, and then actually gain much more from the integration. So just to say, and to summarize, political will, the willingness to change, putting the person at the center and their needs, and really understanding networks, which will have to come with the redesigning on how we finance diagnostics in the future, which cannot be disease specific. But I'm afraid that across the funders, including Unitaid, but also some other funders, we are not there yet, but we're definitely improving that approach, and that's evolving in a very positive way. Thank you.
Thank you very much, Malka. Your answers are spot on. Seeing that we're on the road towards integration, we need to discuss how to measure success of integration. Collins presented on the need for an objective tool to assess diagnostic integration as a means to ensure the provision of adequate diagnostic services using available infrastructure, and assess the agreement on a measure of success of testing integration. How else can we define and monitor the success of integration? And this question is open to all of the panelists. So anybody care to respond, please?
Arlene, I'm happy to kick us off if you like.
Thank you, Jonathan.
I think I touched on this briefly earlier when I was talking. I think the first step is to clearly define goals for the integrated program. I think right now we see a clear definition of goals within each of the vertical segments, but I think that there is a recognition, and it goes back to this redesign, that the goals of integration are not just the sum of the individual goals. We really need to be defining combined goals across integration, and I think the focus here should be around looking at those areas of commonality where we can see the best cost savings, so sample transport, result return systems, etc. And I think defining goals for those integrations, I think, gives us a really good starting point to begin to build systems that are necessary. I think for me, it's interesting how we're kind of circling around certain topics. I think collaboration and co-creation are critical, and in a multi-partner and multi-stakeholder way. So governments, funders, technology partners that could be the laboratory diagnostics industry, but remember there could be other partners like IT and infrastructure companies as well that we should be pulling in. And then I think finally we need to be tying these measurements to the bigger picture. So WHO has defined elimination targets for most of the diseases by 2030. Philippe mentioned the Sustainable Development Agenda and those goals. And I think it's critical that we very practically measure these integration efforts through the patient lens, and really thinking and building M&E systems that really show that we're impacting patients either longitudinally along their own disease journey or kind of at a program level, thinking about how do we bring the care that's needed on the ground where patients need it.
I think you're on mute, Eileen.
Apologies. Thank you very much, Jonathan. Since we're starting to run out of time, we have a couple of questions here for the panelists. And to follow up on Shmalta's comment, given the high cost savings around integration, which has now been demonstrated and well documented in several countries, why isn't there more traction for redesign? We need to understand the barriers and obstacles for redesign. Do we have any comments on this, Shmalta or others? Thank you. Over.
Shmalta, you seemed like you wanted to go, but if I can just jump in quickly here. I think speaking from industry, I think it's very clear from us that there is a willingness from our part to develop a broad assay menu across all our platforms. I think I speak for all of us here, about Roche, Cephei, that all our platforms can run multiple assays. So I think that from the technology point of view, that's already existing. It's now probably at the program point of view where we would need to start to see build traction on that. I think it's been said many times before, and if you think about the Global Fund grant preparations, now since many years, countries are encouraged to have joint grant proposals for TB HIV. Now it needs to move from the grant proposal to actually at the program level to stop having siloed programs, to start having to stop having siloed TB labs, to stop having siloed TB program people. We have seen successes in countries that are now integrating HPV among women with HIV, living with HIV, because they're also at risk. And PEPFAR is doing a great job at funding some of those activities. But we need to see that scaled up and moving from pilots to actually countrywide programs. So from my point of view, I think the technology exists, but I think we need the programs, and I think Jonathan mentioned this, the programs to really start driving this beyond policy level.
Yeah, and Eileen, if I may just add maybe a note of optimism here. I think we all know how things work in the global health environment. It takes time, needs to be demonstrated. We need to have all these pilot demonstration studies, etc., and more. I think the presentations before have demonstrated the value of the integration of testing. This is now understood. This is now supported by the funders. I think in the coming years, and you know that very well, Eileen, where you are, I think we'll see more and more of these things happening. This is the normal course of doing things in the ecosystem of global health. But now I think we're at the point where we'll see integration of testing happening. So I'm very optimistic about that.
Yeah, I want to echo Philippe's comment. I'm also very optimistic, and I would like to invite countries to look into funding opportunities to demonstrate, to generate this data, this evidence for integration also on lab-based high-throughput molecular platforms. So a lot of studies are focusing on near point of care. I know Global Fund can support operational research in the context of their grants. So my invite is really to look at these operational research opportunities for demonstrating the value of integration on polyvalent platforms beyond HIV and TB. HIV and HPV to us looks like a very easy win, because there is less testing for HPV than HIV, but you have women coming to HIV regular visits on a regular basis. So having these systems will improve the efficiencies of the integration, will improve access, and will improve the overall clinical care and clinical management of people with HIV and human papillomavirus. Smilka, over to you. There was a question for you. Sorry, we interrupted you.
No. You have definitely all been very spot on, and I like Philippe's optimism, because I want to see it that way as well. Probably in 10 years, when we look back, we will say, "Oh, this all happened very quickly," even though now we are all frustrated that it's not happening much faster. But there are also other aspects. You know, we have been supporting HPV testing introduction across 10 countries in Africa, and it's not easy from the perspective that the funding is not there yet for HPV testing. So probably the scale that we would like this to see is also informed by the fact that we don't have sufficient funding and sufficient uptake of HPV testing. We don't have sufficient uptake of HIV point of care testing for viral load and EAD. So if we would have the perfect budgets for all these diseases, I think we would be seeing much larger integration scale across countries. But also on the other hand, I think we also have the opportunity now, as the budgets are improving and increasing, to fix some of the remaining things, which is around, I think industry, as I said, I praised you for looking at this holistically. We need to fix some of the remaining glitches in how we look at that kind of split between TB and virology. That's definitely something that we can still do, and that will translate into both the programs, but also how we count those volumes, how we really look at the full integration at the point of care. And really using this kind of slow start to kind of set us for a much bigger success down the road. Thank you.
Thank you all very much, panelists. I think the journey of integration has begun, and we know where there's a will, there's a way. We may be impatient, but we're on that road. I hand over to Pascal for some closing remarks, unless my co-chair has something to add.
Nothing from my end, just thanking you all, and I hand over to Pascal for a closing remark.
Thank you very much.
Thank you, George. Thank you, Eileen, and thanks to all of you for this very rich discussion. I am actually very proud that this level of discussion is happening in the LabCoP. So we heard about the topic of integration, models from the countries, definitions from the stakeholders like CHAI, perspective from the founders, the manufacturer, the solution that they can bring. And I think I'm very optimistic of what is about to come. So the LabCoP, which is really the convener of this meeting, we really commit to continue this discussion with all of you. We heard from the manufacturer, we heard from Francesco, you want to be at the table, and we really commit to offer more opportunities to bring the manufacturers, the laboratory, the stakeholders, the civil society around the table to find solutions and move forward. So integration is a very relevant use case for diagnostic network optimization, but DNO and integration are tools for a larger picture, and we have to keep our eyes on the prize, which is really improving the effectiveness of the network, making them integrated, which is actually what they are supposed to do. I mean, before HIV came and really improved the whole lab system, but also kind of forced us to work in silo, the network were always supposed to be integrated. So we are getting back to where we were supposed to be. And in those conversations, I really hope that we will look and be very creative so that it's not only integration from a technology perspective, and although molecular platform offer really a nice opportunity. We can also integrate from the perspective of the capacity of the workforce, from the perspective of the specimens that are available through sample referral system. And really also, can we integrate based on a microscope? Can a microscope do, bacteriology, and a microscope can also do some other type of examination? I mean, it is really more than the molecular platform. So I would like to thank all of you, and I really want to reiterate that we will commit to continue this discussion within the LabCoP and to make sure that we have good indicator to monitor actually the success and make sure that we take on board all the remark and input from everyone. So I would like to close here and thank you once again for the good discussion.